Are you all wide awake this morning? I hope I woke you up just now. Okay, sorry, there was from some show, kind of a parody from some show some time ago, just to show my age. Okay, by Robin Williams, remember? Okay, never mind. Okay, right. Let's get on to the show. We have another packed program today. We'll not finish until past 5:30. I do apologize. They're so enthusiastic, our organizing committee, that they just can't stop putting more and more speakers in. We just kept going, no more, and then it keeps happening. But anyway, we've got a Malaysian coming on. But he's another Malaysian who's winning awards overseas. Okay, and he's Dr. Ravindran Kanasvaran. It so happens that there's some personal connection with him in that he used to go to school in Singapore with my husband. But unlike my husband who came home to Malaysia, he's remained in Singapore. And he is currently the senior consultant and deputy head in the Division of Medical Oncology in the National Cancer Centre, Singapore. He's also an associate professor at Duke NUS Medical School and a clinical senior lecturer at the Yong Lu Lin School of Medicine, National University of Singapore. So he's really a very, very accomplished speaker. So I think his successes will speak for itself. So over to you, Dr. Ravi.
Very, very kind introduction. It's always a pleasure to be back in this meeting. I've been involved with MCHA for many years now. In fact, nearly 20 years since it first began in 2002 or 2003. If I recall the first meeting, I think it was 2002, so it's 20 years. And unfortunately, I'm not able to travel to Penang because of restrictions on travel by my employer, and also there's no VTL to Penang, but that will be opening up very soon. So I'm going to share my screen. So if you just bear with me for a second, I will share my screen. I hope all of you can see my screen. I think I can see it on your screen. So it should be okay. Let me blow it up a bit. Okay. And that would be that. Yeah. Okay. So thank you for that introduction. I'm currently a medical oncologist at the National Cancer Centre, Singapore. And I specialize in urologic cancer, so prostate, bladder, kidney. But another area of interest of mine is in geriatric oncology, basically the care of older patients with cancer. In fact, the international society that I belong to and now I'm president of, we have kind of moved away from the term elderly and we have termed elderly as older adults. So cancer in the older adults, can we do better? Now, these are my disclosures. So the outline of my talk today, I'll speak about what is cancer in the elderly or older adults, the need for geriatric oncology, what is that field about, what do we do, how can we improve on cancer care for older adults, and can we do better? And finally, I will summarize. So the number of persons aged 65 and older is going to increase tremendously over the next few decades. So as you can see here, this is relatively recent data. The number of persons aged 65 years and older is about 702 million people in 2019. And this is going to more than double by 2050. And a lot of that growth is actually going to come from Asia. If you look at the numbers here for North Africa and Western Asia and also Central and Southern Asia, the percentage change is over 200%. So a lot of that growth is going to come from our region or our part of the world. So it's something to take note of for many governments to be prepared for as well. Now, when we talk about cancer and age distribution, and this is data from the United States, but when we look at this age distribution of cancer in countries outside of the US, it's somewhat similar as well. What you will realize is that it is a disease of older adults. Now, for example, on your left is a pie chart of males with cancer. And as you can see, if you look at ages 60 to 69 plus 70 to 79 and 80 plus, you add all those percentages there, more than 60% of adults with cancer are over 60 years of age, and very similar with females as well. This tells you that cancer is a disease of aging. The older you are, the higher the chance you'll get cancer. And amongst all cancer patients, most are above 60 years of age. Now, this is another piece of data. In this table, again, I'm trying to highlight that cancer is a disease of aging. So when you look at rates of cancer per 100,000 population, it increases exponentially after your age of 65, right? So before that, your chance of getting cancer is not very high. But as you grow older, your risk of cancer is higher. And there's a lot of scientific rationale behind why this is so. Now, the difficulty here is that, yes, as you grow older, your risk of cancer is higher, but so is your risk of getting other comorbidities or other diseases. So here I highlight from head to toe some of the issues that older adults have to face. So even if you don't have cancer, you deal with issues like cardiovascular risk, diabetes, you have reduced organ function. So your bone marrow, your heart, your kidneys are not functioning as well. When you're 60 years old, your kidney is 60 years old as well. When you're 70 years old, your heart is 70 years old as well. And as such, it won't be functioning like a 20-year-old or a 30-year-old. Now, there are other issues as well. Because of your reduced physiologic capacity, risk of toxicities. So when you have to throw in things like chemotherapy, elderly and has medical issues as well, so it becomes very difficult. And impaired function. And last but not least, at that point in time, what they value most is actually quality of life, not quantity of life. And that's something people sometimes forget. So it's very important to have that discussion with patients, regardless of whether they are cancer or non-cancer patients, about quality of life and how some of these treatments may be detrimental to that. Now, older cancer patients are a very heterogeneous group of patients. So on your left is a very fit man on parallel bars. I don't know whether you've seen that in the Olympics. It's one of the gymnastics regimens. And as you can see here, with one of the gymnastic disciplines, and as you can see here, that man is actually balancing on the parallel bars. On the other hand, you have another older adult, a lady, probably same age as the man on the left, and she is on a wheelchair, so she's frail. So you have the whole spectrum from fit to frail. And now I'm going to go from top to bottom, how a lot of factors that, or attributes that they have differ because of their physical functional state. Now, in terms of life expectancy, even if they are the same age, the fitter person would be expected to live 10 years or longer when they are 80 years old versus the lowest 25 or the lowest 25% or lowest quartile who are frail, who are expected to live only 1 to 2 years more when they've already hit the age of 80. So life expectancy is higher if you're fitter. Comorbidities are lower. If you're fitter, you're less likely to have diabetes, high blood pressure. Your functional status is better when you're fitter, as you can see here, and it drops as you become more frail. And because you have fewer comorbidities, you have fewer drugs. So there's less polypharmacy, which is not a good thing. Well, if you have a lot of comorbidities, you have a lot of polypharmacy, a lot of drugs, which come with drug-drug interactions and a lot of other medical issues. Now, your organ reserves are better when you're fitter, and it drops over time when up to a point where you're frail, your organ reserves are barely there, and you are very susceptible to toxicities. And then that's the next graph you can see down there. When you're fitter, you suffer less toxic effects of chemotherapy, while if you're not, you have a lot of toxic effects. Now, the last two are very important because this focuses on goals of care. So now if you're fit 80-year-old and you're doing parallel bars, your focus is on survival because you have good quality of life already and you want to live as long as possible with good quality of life. Now, if you're frail on a wheelchair, your quality of life is poor, not that great. So you're not so focused on survival. You're focused on maintaining whatever quality of life you have. You don't want to become bedridden. You don't want to suffer more pain. So your focus is different. So depending on where you are in the spectrum of fit to frail, your goals of care will differ as well, as shown by the Jenga there. You know, when you're fit, you're all nicely built up. When you're frail, there's so many holes, so many gaps, everything changes. And this is what we need to appreciate when treating our patients. And I guess this extends beyond cancer as well. But more importantly in cancer, because it's such a stressor, it's important to understand these things. Now, therein lies the issue about over and under treatment. So under treatment is, as I defined here, you can see here, under treatment is the use of less intensive cancer treatment in a fit older adult. Now, this very often happens because of ageism. So I give you an example. A patient who's 80 years old walks into a cancer clinic. Very often, the oncologist will look at the age and already have preconceived notions about how fit or frail the patient's going to be, and is more likely to undertreat the patient even if the patient is fit and has the body of a 60-year-old. Now, that's a problem because you're not going to be able to fulfill that goal the patient may have, which is quantity of life or survival, because the patient already has good quality, the patient is fit. Now, overtreatment less likely happens because of ageism again. Because again, once an older adult walks into the cancer clinic and they are 60, 70, 80 years old, it's very likely the oncologist will not want to take a risk by giving too much of a toxic therapy. And so this is less likely to happen, but can happen, because in the same scenario I mentioned with the 80-year-old, if a 60-year-old walked in, very often oncologists may think 60 years old, yeah, they're quite fit. But if the 60-year-old was not fit, had multiple comorbidities, and that was not assessed, then you may end up over-treating the patient. And that's what this particular graph actually shows. There's always a sweet spot. But in order to find that sweet spot, you need to do more tests, better assessment. You can't just do the eyeball test, which a lot of us do. Patient walks in, we eyeball them, we look at them, we decide, oh, they look fit, let's give them this much. They don't look fit, we give them that much. But there's a lot more to a person's physical appearance than meets the eye. Now, unfortunately, can we get any evidence for the use of a lot of the cancer therapies in older adults? And usually that evidence comes from clinical trials. Now, the issue is we don't recruit older adults in clinical trials. So on your left-hand side is a graph showing the number of older adults recruited into clinical trials. The age cutoff is 65 years and older. Now, 63% of the US cancer population are 65 years and older. But how many percent are recruited in clinical trials? Only 25%. So there's underrepresentation of older adults in clinical trials. Now, if there are not enough older adults in clinical trials, how are we supposed to get information about an 80-year-old for a particular drug when it's only been tested on 60, 65-year-olds? So that's a problem. Now, on your right is more recent data. So on the left was slightly older data. Now, on the right is more recent data. And what you can see is that not much has changed as well. Again, for 75-year-olds and above, 28% of the cancer population are 75 years old and above, but less than 10% are enrolled in clinical trials because of ageism. And because when investigators conduct a trial, they want to give it the best chance possible. And for that to happen, they recruit young patients who are not representative of the general population. So we have a lot of evidence gaps in oncology, specifically in reference to the geriatric. We know there's gross underrepresentation, we don't have enough data. So geriatric oncology is really a field highlighting issues into cancer in older adults, addressing them via research, education, and clinical application. Current practice, many centers across the world do not have this practice of geriatric oncology. They just use the eyeball test, as I mentioned, or Karnofsky or ECOG performance status. Now, this is a very simple, basic, rudimentary functional assessment that doesn't really tell you a lot of the other important dimensions that requires assessment of. Now, it's been also shown to be a poor predictor of functional impairment in the elderly. We've already proven that. It's not effective. Functional status alone is not effective. We need every single bit of this. And this is what I mean by a geriatric assessment. You would have heard this. We oncologists borrowed this from the geriatricians who've been using this for decades on their older patients. That's why geriatricians are probably one of the most complete physicians out there. I'm sure Professor Tan is smiling gleefully now as I say that, but that's true because they actually do a very comprehensive assessment of an older adult. As you can see here, they check their functional status, cognitive status, AFEC, nutrition, how fit they are, pharmacy meaning polypharmacy, geriatric syndromes, and they look at comorbidities. I put there CCI because we use the Charlson Comorbidity Index. So we look at every single aspect of their lives. One thing I didn't put there was social support, and that's something I look at as well. So all these are very important components that need to be assessed in order to fully understand whether a patient is fit to receive a treatment, especially toxic therapies that we dish out as part of chemotherapy or systemic therapy for cancer. Now that's where the International Society of Geriatric Oncology has come in a big way. So this society, which I'm very closely linked to, was founded in the year 2000. Geriatric oncology itself is about 30 years old. About 10 years before this society was formed, in like 1990s, there was a lot of development in the field, mainly in North America, specifically in the US, and also in Europe. Now we have over 1,900 members from 80 countries, and every year we meet at a particular location. Mostly it's been in Europe, but we've had it once in the US as well. And we also conduct advanced courses across the globe, both in Europe, and most recently we've been running a yearly course in Canberra. Now, the history, as I mentioned, 2,000 years old. Those are some of our founding members. The pictures are there. And it's always been led by an American or a European. As you can see there, they alternate, they take turns. But 2 years ago, I was the first Asian to be elected to this position, and it provided me with an opportunity to highlight geriatric oncology in Asia. So this was a wonderful opportunity for me to actually lead a global organization and push for geriatric oncology in this part of the world as well. Now, we work with numerous organizations across the globe. That's a picture of our advanced course in Treviso in Italy. We also have programs in Manila, in Canberra, as I mentioned to you. And last year was a big year. These are some of our activities in education. We have, as I mentioned, advanced courses. So even all of you in Malaysia, some of these courses, because they run virtually, you can actually enroll in them. We have a big social media presence. We work with numerous societies, mainly in Europe, but slowly we are forming alliances in India, China, and some parts of Southeast Asia. One of the key things that is important, I think we realize in making a change, is public policy. Similarly, like what MHAS has done in Malaysia in highlighting issues relating to healthy aging, coming out in the press, working with local governments, getting support from the federal government, and we are looking at how we can do this at the global level as well. So last year was a milestone year because we managed to get a special consultative status with the United Nations. We had our first public policy meeting in the UN in 2019, and this year I'll be organizing one with our meeting in Geneva. Our annual meeting this year will be in Geneva. So SIOC headquarters is actually in Geneva in Switzerland. We also have our own impact factor of 3.6. So if you're interested in submitting any articles related to older adults with cancer, please consider our official journal as well, Journal of Geriatric Oncology. Now, public health policy was a major pivot over the last 4 years, and this was our meeting at the United Nations 3 years ago in 2019. And only through public policy, I think we can actually make meaningful changes. Every single individual out there can't make a difference. Of course, that matters as well. About 11 years ago, we came up with this thing called the SIOC 10 priorities. We wanted to improve education, clinical practice, and research, and we came up with certain general priorities or principles that we felt our members who are from countries across the world could apply in their respective country. And wherever they had issues, their challenges, we will support them. So these were the 10 priorities to develop geriatric oncology, at that time published in the Journal of Geriatric Oncology. Most recently, we updated it, so I was part of this publication as well. We are now looking at 12 priorities, the last one being collaboration and partnerships. So this includes working with organizations across the world, and of course I'll be keen to work with organizations in Malaysia as well to develop this field. In fact, recently one of the oncologists in Malaysia from University of Malaya had got in touch with me, and we are looking at how to collaborate to set up a geriatric oncology clinic in UMMC. So that would be a major step forward. So like that, we have added collaboration and partnership as another 3 priorities. So from 10 priorities, we've gone to 12 priorities right now. So of course, focus is very much on education, how we translate that knowledge into clinical practice, and how we push the boundaries by learning more about older adults with research, which is priority 789. And finally, as I mentioned to you, collaboration and partnerships, which we look forward to building links across the world. Now, can we do better? How's the rest of the world doing? And how has COVID-19 thrown a spanner in the works? Now, in North America, geriatric oncology is pretty well developed. As you can see there, we have national representatives, SIOC members who lead the society there in the US. We have selected geriatric oncology clinics. You see it's scattered all over the United States. They have formal geriatric oncology fellowship programs. About 11 years ago, I did a fellowship in geriatric oncology after finishing my oncology training in Singapore at Duke University, which is one of the dots there. And that's how I got involved in geriatric oncology. I did a dual fellowship in urology and geriatric oncology, and came back and started running the clinic here in Singapore. We also actively collaborate with a research group there called CART, Cancer and Aging Research Group. And they have a big oncology organization called ASCO, American Society of Clinical Oncology, which has over 40,000 members. And we work with them on a geriatric oncology program at their yearly meeting. Now, Europe has the highest population share of oldest adults in terms of proportion, and they have many programs you see all over there. Unfortunately now, there's war, but most of it is in Western Europe, and they're all still running. They have comprehensive and shared care model. Now, let me talk to you a bit about the models of care. So, geriatric oncology itself is not a specific specialty where you train and you just become a geriatric oncologist. Most oncologists specialize in certain tumor types globally. Of course, in many countries in Asia, we don't have that luxury, so they see all kinds of tumors. Now, geriatric oncology is actually having that knowledge base in being able to treat older adults. So, in fact, our tagline in SIOC is to make every oncologist realize that they are geriatric oncologists. And that's our goal, to make every oncologist realize they are all geriatric oncologists. Why? Because most of their patients are old. So every oncologist, treating oncologists out there, needs to have this skill. And that's what we're trying to promote. We're not promoting a specialty. We're promoting knowledge to every single person who treats cancer. Surgeons, it doesn't matter. You need these principles. So, multidisciplinary setup. So there's an surgeons, radiation, there's a geriatrician who's very important, there's physiotherapists, occupational therapists. Allied health is extremely important. Many of these patients need physio, need occupational therapy, speech therapy, they need pharmacists involved. So you need multiple different specialties, social work as well. So that's a comprehensive model. A shared care model is where you refer. So an oncologist refer to geriatrician, geriatricians will assess, then refer to a physiotherapist or a rehab physician to lead that rehabilitation. So there are a lot of different kinds of models. As mentioned to you, we also work with some big groups. So ESMO is another large oncology group with 27,000 members. And our headquarters itself is right in the middle there in Geneva, where we have our annual meeting this year. Now, Latin America is growing. Large proportion of older adults coming there and will grow in the future. They started their first geriatric oncology clinics in 2011. Now they have a few in Brazil, in Mexico, and we had our first Latin America meeting in 2019 there. Asia, more than 50% of global cancer incidence and mortality occur in Asia, mostly in India and China. They are 2 of the top 5 nations with cancer. In fact, you need to add Japan as well. So 3 out of the top 5 countries in the world with cancer incidence are in Asia. And there are unfortunately very few countries. So Singapore has a geriatric oncology clinic. Hong Kong just started theirs. Japan has a few. We have, one in India, and China has 1 or 2 clinics as well. So because of that, in 2019, we decided we had to work with some of these countries. So we had a public policy meeting with all the ministers from Southeast Asia in Manila, and there was a very fruitful meeting that pushed forward some of these geriatric oncology principles that SIOC stands for. Now, Oceania looking at Australia, New Zealand. There's no formal geriatric oncology training program, but there are societies there, the Cancer Clinical Oncology Society of Australia, has a lot of research and educational programs running across the country, so they have a pretty well developed system going on there as well. So globally, we are building. We're still lagging a bit in Asia, and being in Asia, I feel responsible that we should start building capacity in this space as well. Now, COVID-19 was a bad thing to happen for everyone, and I know many of you have suffered and even have family members now who have COVID, who are unwell, and I hope everyone will recover from this soon and get out of this in the next year or so. But for cancer patients, it was the worst thing possible. So this was data coming out of what was called the COVID-19 and Cancer Consortium, and this consortium actually looked at multivariate analysis looking at 30-day all-cause mortality. And one thing that stood out was that if you had cancer and you were old, right, you had the highest risk of deaths without ICU admission. Why? Because ICU was limited. When the pandemic first hit, it was in Europe. After China, it was in Europe. So Italy was hit very badly. Italy has a very high proportion of older adults. Now, what happened was ICU beds started running out. So ICU consultants and specialists had to triage. They had to choose. So if two patients came in, one was 50 and one was 75, and they had one ICU bed, guess who the ICU bed went to? Now, so obviously we go to the younger one, right? Now, if you have two 75-year-olds, one who was relatively well, no cancer, and another 75-year-old with stage 4 cancer, and only one ICU bed, guess who got the ICU bed? The one without cancer. So patients who were old, and a double whammy was when they had cancer, are less likely to have got any form of treatment. They not only wouldn't have got treatment for COVID. If they did survive COVID, a lot of their cancer treatment would have got delayed, or their diagnosis would have got delayed, and they would have died much faster from their cancer. And that was the problem that they had. So this is what I wanted to highlight. So with older adults, you have treatment goals, treatments that we can offer cancer patients. We have patient-related issues that I mentioned, doing the GA, the geriatric assessment. You have tumor-related issues. We have resource issues. But ultimately, the curveballs were when you had these problems, and COVID-19 was a major problem for older adults with cancer. So we formed a COVID-19 working group and came up with some protocols to help countries treat their cancer patients who are older without compromising their health. So what we did was also provide some guidance on telehealth. I don't know how big it is in Malaysia at this point in time, but in many countries in Europe and the US, they moved towards a telehealth-based system, and we moved our geriatric assessment that way as well. Now, geriatric assessment tell you it takes a lot of time, a lot of effort, a lot of resources. So we'll do this with cancer patients without having to is to do a screening test. And that we use what is called a G8. G8, as you can see here right in the middle, it's actually a group of 8 questions, as you can see here, that are asked to the patient, and this can be sent online. So we started in 70 program to come to National Cancer Center Singapore was sent a G8 to their handphones before they came here as an SMS with a link. So they did it online, and by the time they arrived here, we knew who needed a full GA and who didn't, because this was a screening test. Those who score 14 and above didn't require a GA, but those who scored less than that required a GA, and that's how we use this screening tool. So people pivoted to online ways of doing this. However, there are a lot of restrictions as well. You needed a patient group or profile that was educated, that's technology savvy to some extent, can use their smartphone, can answer these questions. So that can be a challenge with older adults, especially in this part of the world. So it's not so easy, but over time, I think this will be one of the ways to go to save time and also protect our patients from exposure to COVID-19, especially when they don't need to come to a hospital if they don't have to. So in summary, older adults with cancer form a significant proportion of cancer patients globally, and this proportion is increasing with time. Geriatric oncology plays an important role in addressing issues unique to older adults with cancer. And SIOG is leading the charge with coming up with priorities for development of geriatric oncology globally. And time has come for us to work together to address disparities. Why should older adults get inferior treatment? Why should we undertreat them? Why are they neglected? Why do we assume, and many of us in the audience are younger with older parents, and why should we assume that they will not be able to tolerate treatment? Why should we deny them treatment? Have we spoken to them about their goals? So these are disparities that need to be addressed. These are questions that need to be answered. And it can only happen when each and every one of us dispel ageism and look towards helping our older adults, regardless of whether they have cancer or not. And with that, I would like to invite all of you to our next meeting. I know it'll be difficult to travel, perhaps, but we'll likely have a virtual platform as well. So feel free to join us. Our website is www.siog.org. If you just Google SIOG, you should be able to find us. And feel free to sign up as a participant in the meeting. So we hope for better outcomes for all our older patients with cancer. With that, I thank you very much.
Thank you very much, Dr. Ravi, for that very clear plenary. I think it's expertly delivered. Okay. Normally we will have no questions for plenary, but I don't think we should let Ravi off so lightly, right? Because he's presented us with such amazing, groundbreaking work. And I think when you said something about older people being denied treatment, I mean literally denied treatment, isn't it? During the COVID-19 pandemic, I think I was sitting opposite Prof. Sharul, our president. It's like a knife being stabbed into your heart, because this is literally probably why a lot of you are here today, because of the guilt that society has actually ignored the plight of older people, thinking that we are a caring nation, etc. So from your experience, dealing with all these international people, was there a perception that Asians cared more about older people?
No, that's a good question. I think there may have been that perception because of the familial structures within Asian communities and Asian families. So very often in Western societies, especially in North America, to some extent Europe, but maybe not as much, it's all about the nuclear family unit. And sometimes that means the older adult or the parent is left alone, staying alone somewhere. Although many of them may be independent, but COVID obviously changed all of that. So they may be living with just their partner. While in Asian societies, many parents actually live in extended families. So the perception was, yes, maybe, in Asia, a lot of Asian families were able to support their families through COVID. But that's increasingly not true. I think in many urban cities, things have changed. People don't live in extended family structures anymore. They're all nuclear units. Parents live separately. Fortunately, in a country like Singapore, because it's so small, even if parents live away, they're not very far away, so it's not too bad. But if in countries like Malaysia, my dad is in Ipoh and I'm here in Singapore. My sister's in KL. And there are other people in Malaysia who are in smaller towns and their children are in KL or Johor or Penang, because that's where jobs are. So not too bad still. They could still bring them over. But during the time of lockdown, when they didn't allow travel on highways, unless you have very good reason to move from one state to another, it was really hard for older adults. And so it didn't matter whether you had a extended family structure or not. Sometimes just being physically away is a big issue. So I think while the perception may have been Asians may have gone through it well, but the reality on the ground was it didn't, right? We all know that for a fact. There were so many lockdowns everywhere. So unless you're a small city and everyone stays within the city like Singapore, outside of that, in any other relatively big country, it's still a problem, and many older adults suffered during the time.
Yeah, I'm going to come up with the next question, but please, members of the audience, if you've got any questions, please put up your hand and we will run to you with the mic. Yeah, okay. So I'm going to ask the next question. I'm going to talk about the other way round now. So we talked about the COVID-19 pandemic when older people are denied treatment, but there's this lack of safety nets, if you like, for our older people when it comes to financial provision for cancer care, isn't it? Because I used to work in the UK, but the best example, probably when it comes to healthcare provision for older people, is actually the United States of America, where we always know United States of America is a country where 50% of people don't have any access to healthcare. But if you are over 65 in America, the government pays 100% for your healthcare. In Malaysia, if you're over 65, nobody pays for your healthcare except your family, so they have to sell the house. They have to do that. Why? Because society is judging. It's your parents, it's your responsibility to look after your patients. So when you were dealing with these cancer circles internationally, was there any talk about, what's the optimal way of actually providing for cancer care in older people? Because it is ridiculously expensive, isn't it?
Yeah, it is. No, it's an excellent question. I think how I'd frame it is around the theme of healthcare financing. And I mean, you can see in the US, of course, more than 65, you're covered. But number one, you're not covered for everything. And number two, if you look at the percentage of GDP spent on healthcare by the US, and of course, it's a rich country, it's nearly 20%, 18 to 20%. So it's a big burden on the economy. Most countries in Asia hardly spend anywhere between 5 to 10% of their GDP on healthcare. They put in other things like education. Of course, it's necessary to focus on those things as well. And a lot of these countries yet to see the silver tsunami. So the elderly group is not that large yet. So as of this point, unfortunately, still they are widely ignored. And that's why in societies like MHS are important to highlight some of the issues suffered by the older adults. Now, coming back to your question about perceptions, I think, yes, here in Asia, it's not just perception. The reality is most of our cancer patients can't afford a lot of these therapies. But that's why lobbying the government and getting, advocacy groups working on these, topics are extremely important, because the government needs to realize that once an older adult gets cancer, if treated early and appropriately with the right treatment, some of them can still contribute economically, okay? And in the long run, may not be as much a financial burden. So sometimes it's being penny wise, pound foolish, and they need to realize that now. The only way to help them realize that sometimes is also for academics across the country to do cost effectiveness analysis and things like that. And you can then pick and choose the appropriate kinds of therapies, because there are a lot of treatments out there. There are drugs developed for billions of dollars that industry will tout as the next game changer. But at the end, if it's going to buy you 3 months of survival, is it worth having that drug? So you need to firstly form a group that looks at cost effectiveness at the government level. So Ministry of Health needs to consider that, and then pick and choose therapies that are worth putting into the blue book in Malaysia, for example, for physicians to use that, and not just totally ignore and say everything is expensive, everything is useless. So by doing that kind of thing, actually you may find a very good balance between delivering good quality, high quality care to older patients with cancer versus crippling the budget, the healthcare budget. So there can be a good balance there. So not necessarily all these drugs are super expensive. Now, many of these drugs have become generic, they're off patent, and some of them are biosimilars now. Biosimilars means that these are biologics, and they are made with a similar kind of molecular configuration with similar benefits, and they are much, much cheaper. So that's what we are pushing for from a public policy initiative globally. Go for generics, go for biosimilars, go for cost-effective analysis, and it'll be a worthy investment. I'm sure there are many experts in Malaysia in this field, and the government should harness their knowledge to do cost-effective studies on these drugs. And you'll find some of them, maybe a bit expensive, but in the long run, really beneficial for your patients.
Fantastic answer. Thank you so much. Really, are you really going to not make it difficult for him to leave? No? Okay, I've got another question then. So, and then one of the other things that really is quite burdensome to me, because in a society where people have to sell houses, have to borrow money and go into big debts to actually fund treatment, we do not always consider the cost of treatment as part of an ethical consideration for decision making. So, for instance, I'm going to give an example because I've got another 5 minutes. So you all don't want to ask questions, I thought, right? So then we have our pride and joy, the COVID clinic. Yeah, we managed to set up a post-COVID clinic, and we have a geriatric post-COVID clinic in the University of Malaya Medical Center. So, and some of the people who helped make it possible are actually in this room today. So that's our pride and joy. But with regards to the geriatric COVID clinic, this patient comes back post-COVID, and we're having this happy banter about, you know, her horrible experience, and then we managed to turn it into a joke. And then after that, she says to me, I've had this heartburn, you know, this pain in my stomach for the past few weeks. So then my face dropped and her face dropped because she knows what I was going to say. I said, you know, I think you need to have a scope. Then she says, no, tana. So I was like, okay. And you know that the tana has a lot of meanings because she knows that her friends have had scopes and they found something and then. So the family had to then, you know, someone has to give up work to look after them while they went through a series of operations, cancer chemotherapy, and after that the patient's family still died. And then, you know, the family had were left poor, and then the friend was no longer there. So she kind of had that picture in her mind. And then I said to her, you do know that, you know, what we're looking for, if I want to just rule out cancer, we catch it early, then we can potentially just, you know, cut it out. And then she just went, tana. So I was like, okay. So we left it as that because I totally spoiled my lovely patient-doctor rapport after that. But what would you say to a patient like that?
I think that highlights some of the societal taboos. You know, a lot of people out there, especially in Asia, this part of the world, feel that once you get cancer, number one, it's a death sentence. Number two, you're going to be a burden to the family. Number three, the treatment involves a lot of suffering. So these are some, to a great extent, myths because they're not really necessarily true. So to address them, so number one, you know, if you diagnose cancer early, as what you mentioned, Mopin, it can be cured, okay? So, which means it's not a death sentence. So that's important to know. So at least they need a diagnosis, okay? Number two, are they going to be a burden to the family? If they are cured, they can lead a normal life again. So they're not going to be a burden to the family. And even if they're not cured and it's stage 4 cancer, we can give drugs that can maintain their quality of life. The goal is not to give drugs to make them suffer. The drugs are to control the cancer so the cancer doesn't make them suffer. So they may not be a burden to their families. And nowadays, of course, there are more cost-effective therapies coming into the market. And the third myth, of course, is are they going to suffer from the treatment? Now, treatments have evolved over time. It's no more the chemotherapy that people think of when they watch a drama serial. You know, patients lose their hair, they're on a drip, and they are on the bed all the time. It's not necessarily the case with many new targeted treatments which are oral or immunotherapies which do not have side effects like losing hair and things like that. So all three are myths that need to be debunked, and the only way to do that is with you know, patients gaining awareness of these things. So that's why it's important to have public education programs, get the families involved. If patients say Tanak, then call the children in. They may be better educated, better able to accept these explanation, and then they can explain to their loved one or their parent why this is actually overall good for the parent. And so there's so many ways to get around this. I think you just have to work with families for now, because sometimes patients may have already made up their mind by the time you talk to them.
It's very tough because sometimes we end up colluding with family members, which is the other problem.
Not ideal.
Yeah. Yes, I know. Yeah. So I've got a couple of questions from the virtual audience. How much funding does cancer research / treatment get from the annual health budget or MOF budget in Singapore?
Oh, what proportion? I can't tell you that, because there are multiple sources actually, not just from the Ministry of Health, or there's also Ministry of Education. So what proportion, I can't tell you exactly. The sources, mainly the government, but we also do a lot of industry collaboration and philanthropy. So we actually get a lot of donors coming in to help support our programs. And for myself per se, most of my funding is actually from philanthropy or donors, because it's a clinical program. It's a bit harder to compete for research funding with you know, the labs. So I don't run a lab. Mine is purely a clinical research program. And currently my biggest pool of funds are from donors.
Great. And how many oncologists are there in Singapore?
Medical oncology, we have approximately maybe 140, and half of them are in my center. So medical oncology, about 70 in my center right now.
Yeah.
And we specialize in various fields. So there are 4 departments. So I'm the deputy chair for the division, and we have 4 departments under the division. So each one has a specialty of its own. There's lymphoma, there's breast and gynae one, and then there's lung and urology cancers, and the last one is all the GI cancers. So we do subspecialized care, which makes it, I guess, in a sense, easier as well, because like myself, I only see prostate, bladder, kidney, testes, and that's all I do. So makes it easier to go in depth into that field, because cancer care has become very complex. So to become a generalist is really, really hard nowadays.
Okay. Right. And one last question. Okay. Someone asked about SIGO. Do you have lay people in SIGO, and as well as allied health professionals?
Sorry, in the about
your
SIOP.
societies, yeah.
Yes, okay. Oh yeah, of course, huge. So we have the NAH, which is Nursing and Allied Health section of SIOP. So we have nurses, we have occupational therapists, physiotherapists, pharmacists. They all come under Nursing and Allied Health. So that's a very strong arm of SIOP. So a big part of membership, because geriatric oncology is actually a multidisciplinary field. It's not about oncologists alone. It's about everybody else, actually. It's about the nurses and allied health, pharmacists, physiotherapists. We also have a young division, young SIOPs. These are for junior members. The fees are cheaper if you're in training in any of these fields, whether it's nursing or oncology, you can join. We also have recently formed a translational research group as well. So we have multiple groups, but yes, a big number of our members, a big proportion are nurses and allied health. So if you go under SIOP NAH, Nursing and Allied Health, you will be able to find those groups.
Great, thanks. Now it's 9:15, so we'll have to call it a day. Thank you
Yep.
so much, Dr. Ravi, for actually that amazing talk and for the answers to those challenging questions. Thank you.
Thank you, Prof. Tan, and have a great meeting, everyone. I know it's the last day already, so have a great